Pediatric Surgery Part 2 Disorders of Intestinal Rotation. Embryology. The fetal intestine begins as a straight tube which grows faster than the abdominal cavity, so it herniates out into the body stalk, future umbilicus, at about from 4th to the 6 weeks gestation. At 10th to 12 weeks, the bowel returns to the abdominal cavity, rotates, and becomes fixed to the retroperitoneum along diagonal axis extending from the level of the left of T12 vertebra to the level of the right of the L5 vertebra. The duodenojejunal portion of the gut rotates counterclockwise posterior to the superior mesenteric vessels for 270 degrees and becomes fixed at the ligament of Treads and located to the left of and cephalic to the superior mesenteric artery. The cecocolic portion of the midgut also rotates 270 degrees but clockwise anterior to the superior mesenteric artery. The cecum becomes fixed in the right lower abdomen at L5 level. Incidence of anomalies rotation and fixation occurs in males twice as common as females. Classification: non-rotation, incomplete rotation or malrotation, reversed rotation, and anomalous fixation of the mesentery. Non-rotation: the midgut is suspended from the superior mesenteric vessels, small bowel is located on the right side, and large bowel is located in the left abdomen. No fixation occurs and adhesive bands are not present. This is the fetal anatomy prior to the 10 weeks gestation. Because its base is so short, the mesentery is narrow and volvulus occurs with clockwise twisting of the bowel around the superior mesenteric vessels, usually found in patients with omphalocele, gastroschisis, and congenital diaphragmatic hernia. Incomplete rotation or malrotation. It may affect the duodenojejunal or the cecocolic segment or both. Adhesive bands or Ladd's bands are usually present in the most common form. The cecum stopped rotating and fixed near the origin of the superior mesenteric vessels, so dense peritoneal bands extend from right flank to the cecum, obstructing the second or third portion of the duodenum or other small bowel segments. The duodenojejunal segment also only partially rotates, usually stopping at or to the right of the vertebral bodies. The intestinal mesentery is fixed posteriorly, but is very narrow, extending only between cecum and duodenojejunum, leading to volvulus. Reversed rotation: the bowel rotates varying degrees in a clockwise direction about the superior mesenteric axis. The duodenojejunal loop is anterior to the superior mesenteric artery, and the cecocolic loop may be pre-arterial or may be rotated clockwise or counterclockwise in retroarterial position. The most frequent anomaly is retroarterial clockwise rotation, and it causes obstruction of the right colon. Anomalous fixation of the mesentery: it leads to internal mesenteric and paraduodenal hernias, a mobile cecum, or obstructing adhesive bands in the absence of anomalous bowel rotation. Excessive rotation of the duodenojejunal junction: it makes the superior mesenteric artery, compresses the third portion of the duodenum. Clinical picture: type of the patient: the majority who develop intestinal obstruction are infants. Older patients may develop intermittent obstruction. Symptoms: symptoms related to intestinal obstruction: the 4 cardinal symptoms: pain, vomiting, distension, and absolute constipation. Peptic ulceration or malabsorption, duodenal obstruction by bands, minimal abdominal distension, midgut volvulus, marked abdominal distension. Signs: bloody stools and signs of peritonitis, indicating intestinal infarction. Vomiting of bile occurs initially, and adhesive bands leads to obstruction in the duodenum. Volvulus leads to adhesions in the upper jejunum. Investigations: plain abdominal X-ray with obstructing Ladd's bands, double bubble sign mimicking duodenal stenosis. Normal distribution but minimal amount of gas throughout intestine. When volvulus occurs, the proximal bowel will be distended with gas early, and later ischemic bowel resorbs this gas and it becomes gasless abdomen. The intestinal walls are thickened. Barium meal follows through, showing distension of the duodenum, abnormal positioning of the duodenojejunal segment, and usually to the right of the midline, and narrowing at the point of obstruction. The small bowel is commonly visualized on the right side of the abdomen and the colon on the left. Contrast enema: it shows abnormal position of the cecum. Treatment: the Ladd's procedure: through a transverse upper abdominal incision, 6 key elements in operative correction of malrotation. entry into abdominal cavity and evisceration, counterclockwise distortion of the bowel, division of large cecal bands, broadening of the small intestine mesentery, incidental appendectomy, and placement of small bowel along the right lateral gutter and colon along the left lateral gutter. Meconium ileus. Incidence in 10 to 20% of infants born with cystic fibrosis. Meconium obstruction with no apparent cause has also been described in newborn infants. Common complications of meconium ileus are related to the almost universal presence of cystic fibrosis. Pathogenesis, the thick mucus secretions of the small bowel, condense the meconium, leading to obstruction. Site, usually occurring in the terminal ileum. Clinical picture, very distended abdomen, bilious emesis occurring early, no meconium is passed, and normal birth weight, with finally loops of thick, distended bowel which may be seen and palpated. Complications, repeated pulmonary infection with chronic bronchopneumonia, bronchiectasis, atelectasis, and lung abscess. Pancreatic insufficiency leading to malabsorption, requiring pancreatic enzyme replacement. Investigations, plain abdominal X-ray, showing loops of bowel which vary greatly in diameter. The thick meconium gives ground glass appearance. Air mixed with meconium, the soup bubble sign, usually in the right lower quadrant. Contrast enema, it shows microcolon with rare meconium flecks, and reflux of the contrast through the ileocecal valve, showing small terminal ileum containing pellets of inspissated mucus more proximally. The meconium is packed and progressive distension occurs. Treatment, non-operative treatment and operative treatment. For the non-operative treatment, it's successful from 60 to 70% of the cases. A nasogastric tube should be inserted and connected to the suction. A contrast enema, both diagnostic and therapeutic, is performed with slightly hypertonic water-soluble contrast agent. Never use barium. The addition of N-acetylcysteine is a mucolytic which disperse the meconium in uncomplicated cases. Will hydration by IV fluids during and after the procedure prevent hypovolemia, which is caused by the hypertonic contrast solution. Operative treatment, laparotomy. Indications, failure of non-operative treatment. Steps, ileum is opened and, if possible, flushed to clear. Bowel re-anastomosis or bring it out as a double-barrel stoma. Alternatively, a T-tube may be placed in the bowel and brought out of the anterior abdominal wall for post-operative irrigations. Compromised intestine is resected. Appendectomy is performed because the high rate of appendicitis in patients with cystic fibrosis. Hirschsprung's disease. Etiology. Due to failure of the cephalocaudal migration of the parasympathetic mesenteric nerve cells into the distal bowel, a familial association occurs in 5 to 10% of cases, more frequently when females are affected. Down syndrome occurs in 10 to 15% of those patients. The length of the involvement tends to be consistent in familial cases. Females tend to have longer aganglionic segments. Extensive involvement of the small bowel is rare. Incidence: males are affected 4 times more frequently than females when the disease is limited to the rectosigmoid. Site: the absence of ganglion cells always begins at the anus, extending to a varying distance proximally. Short segment aganglionosis, involving only the terminal rectum, occurs in about 10% of cases. The disease extends to the sigmoid colon in 75% of cases, more proximal colon in 10%, and the entire colon with small bowel involvement in 5% of cases. Pathogenesis: the aganglionic bowel fails to relax in response to distension, leading to functional bowel obstruction. Normally, the neonatal rectum is wider than the rest of the colon, including cecum. When the rectum is seen to be narrower than the proximal colon, Hirschsprung's disease is suspected. The symptoms are variable in severity, but almost always occur shortly after birth. Clinical picture: symptoms. The infant passes little or no meconium within 24 hours. Chronic or intermittent constipation, laziness, reluctance to feed, poor growth and development, diarrhea, irritability, bilious emesis, and finally progressive abdominal distension. In older children, chronic constipation, abdominal distension, both two are characteristic. passage of flatus and stool requiring great effort, and the stools are small in caliber. Signs: rectal examination showing expulsion of stool and flatus with remarkable decompression of the abdominal distension. Investigations: plain abdominal X-ray showing dilated loops of bowel, difficult to distinguish small and large bowel in infancy. A contrast enema: don't clean out the stool before the fluoroscopic examination because this will obscure the change in caliber between aganglionic and ganglionic bowel. It shows a narrow contracted aganglionic segment with dilated proximal bowel having circumferential, smooth, parallel contractions, similar to those of the jejunum, which are exaggerated contraction waves. Irregular, bizarre contractions, saw-toothed pattern which don't encircle the aganglionic portion of the bowel. Radiographs of the abdomen and lateral pelvis should be repeated after 24 to 48 hours. The contrast agent will be retained for prolonged periods and saline enemas may be required to evacuate it. The delayed film may show the transition zone and the bizarre irregular contractions more clearly than the initial study. Instrumental, we have rectal biopsy, which is the most diagnostic, and manometric studies. Manometric studies rarely performed except in older children, showing failure of relaxation of the internal sphincter following rectal distension by a balloon. Rectal biopsy, the most diagnostic method, mucosal and submucosal biopsies taken from the posterior rectal wall with suction biopsy capsule without anesthesia at the bedside. Serial sections showing characteristic lack of ganglion cells and proliferation of nerve trunks in Meissner's plexus. If findings are vague, remove a 1 or 2 cm full thickness strip of mucosa and muscularis from the posterior rectum proximal to the dentate line under anesthesia, and this is sufficient for the pathologist to determine the presence or absence of ganglion cells in Meissner's plexus or in Auerbach's plexus. Differential diagnosis: rectal or clonic atresia, meconium plaque syndrome, meconium ileus, functional causes such as hypermagnesemia, hypocalcemia, hypokalemia, hypothyroidism, occurring early in infancy and showing stools normal in caliber, soiling is frequent, rare enterocolitis, palpable stool in the lower rectum, and the contrast enema showing uniformly dilated bowel to the level of anus. Hirschsprung's disease in patients who develop enterocolitis and diarrhea may mimic other causes of diarrhea. Short segment Hirschsprung's disease may be difficult to differentiate it from the functional causes, and rectal biopsy may be necessary. Treatment: traditionally, the surgical treatment was staged, a level colostomy after several months, resection of the aganglionic bowel, and performance of a pull-through procedure. Recently, a single-stage procedure, no colostomy in newborn. This model is as follows. Number 1, bowel obstruction and enterocolitis. If they are present, placement of a large 30F rectal tube and repeated warm saline irrigations in 10 milliliters per kilogram preoperatively, and in infants with moderate to severe enterocolitis, diverting colostomy. The correct ganglionic level for the stoma is established as time of the surgery by frozen section analysis of the colonic muscle. For infants who are not ill, undergo any of the 3 effective operations: Swenson operation, Swab's operation, and Duhamel operation. In contrast to the Swenson and Swab's procedures, the Duhamel operation or Duhamel operation leaves a cuff of aganglionic rectum along which the ganglionic bowel is stapled, and creating a mini reservoir. A transanal mucosectomy has been used for those babies with short segment disease. Main principles: removal of most or all of the aganglionic bowel, preserving the surrounding nerves to the pelvic organs, and anosmosing ganglionic bowel, confirmed by frozen section analysis to the rectum 0.5 cm above the dentate line. Meconium plug syndrome or neonatal small left colon syndrome. Incidence: 2/3 are males. Pathology: this problem of newborn infants consists of low intestinal obstruction associated with left colon of narrow caliber and dilated transverse and right colon. Hypermagnesemia has been occasionally associated with the mother, has been treated by IV magnesium sulfate for eclampsia. Clinical picture: symptoms: little or no meconium is passed, progressive abdominal distension followed by vomiting. Signs: rectal examination, normal or may reveal a tight anal canal. After thermometer or rectal stimulation by finger, some meconium and gas may be evacuated. Investigations: contrast enema showing very small left colon to the level of the splenic flexure. Proximal to this point, colon and small intestine are greatly distended. In about 30% of cases, a meconium plug is present at the junction of the narrow and dilated portion of the bowel and the enema. Using water-soluble contrast will dislodge it. Differential diagnosis: Hirschsprung's disease, Meconium ilieus. These lesions rarely cause obstruction at the level of the splenic flexure. Treatment: a nasogastric tube should be inserted. Start IV fluid, a contrast enema to differentiate the various causes of low intestinal obstruction. When left colon is narrow and contrast refluxes into the dilated proximal colon, small left colon syndrome. The enema is usually followed by evacuation of a copious amount of meconium and decompression of the bowel. After enema, if the colon decompresses without further obstruction, Hirschsprung's disease is unlikely to be suspected. Incompletely evacuated of meconium or symptoms persist, take a suction rectal biopsy to rule out Hirschsprung's disease. Imperforate anus. The normal continence mechanism for bowel control consists of smooth muscle, which is internal sphincter, striated muscle, complex of levator ani, and external sphincter. The striated muscles assume a funnel shape, originating from the pubis, pelvic rim, and sacrum, converging at the perineum, while fussing the internal and external sphincter. Most of the striated muscle complex consists of horizontal muscles contract against the wall of the rectum and anus, and longitudinal muscle fibers which are cephalocaudal, elevating the anus. Embryology: anomalies of the anus resulting from abnormal growth and fusion of embryonic anal hallux. The rectum is normally developed and the sphincter is usually intact. With proper surgical treatment, the sphincter will function normally. Anomalies of the rectum resulting from faulty division of the cloaca into the urogenital sinus and rectum by the urorectal septum. The internal sphincter and striated muscle complex are hypoplastic. Surgical repair results in variable degrees of continence. Classification: low anomalies and high anomalies. Low anomalies: the site of anus anterior to its normal position or in normal position with a narrow outlet due to stenosis or anal membrane. There may be no opening in the perineum, but the skin at the anal area is heaped up and may extend as a band in the perineal raphe, completely covering the anal opening. A small fistula, usually extending from the anus anteriorly to open in a raphe in perineum, scrotum, or penis in males, or vulva in females. Often have well-developed perineal and gluteal musculature, rarely having sacral vertebral anomalies. High anomalies: the rectum may end blindly in 10% of cases, but more commonly there is a fistula to the urethra or bladder in the male or the upper vagina in females. Often having deficient pelvic and gluteal innervation and musculature, poor prognosis for continence after surgical repair, high incidence of sacral anomalies, and the most severe of the high deformities is a cloacal anomaly. There is a common channel between the poorly developed pelvic structures, urogenital sinus, and rectum, with single perineal opening. Clinical picture: by physical examination in low anomalies, an ectopic opening from the rectum can be detected in the perineal raphe in males, or lower vagina vestibule or fourchette in females. In high anomaly, no orifice or fistula can be seen upon examination of the perineum. Meconium is found at the erythroid meatus, in urine or upper vagina. Absence of external sphincter contraction with cutaneous stimulation of the anus. Differentiate between high and low lesions. Complications: associated anomalies occur up to 70% with high anomaly. The associated vectoral syndrome includes V vertebral, hemivertebrae, or agenesis of one or more sacral vertebrae, agenesis of 81, 82, or 83. Corresponding neurological deficits leading to neuropathic bladder and greatly impaired continence. A for anal, imperforate anus. C, cardiac, anomalies of the heart, VSD, ASD, and fallout. T, tracheal, tracheoesophageal fistula. E, esophageal, atresia. R, renal, genitourinary anomalies up to 50%. L, for limbs and digits, delay in diagnosis, leads to excessive large bowel distension and perforation. Rectourinary fistula, reflux of urine into the rectum and colon, leading to absorption of ammonium chloride and acidosis. Colon contents will reflux into urethra, bladder, and upper tracts, leading to recurrent pyelonephritis. Anomalies of vertebrae and urinary tract occur in 2/3 of all patients with high anomalies and in 1/3 of males with low anomalies. Vertebral abnormalities in females indicate a high imperforate anus. Investigations: plain X-ray, position, across the table lateral film or lateral film of the pelvis with the baby inverted, Bankstein invertogorum, more commonly used, an inaccurate method of establishing the lower extent of the rectum because swallowed air may not have completely displaced the meconium. Striated muscles complex may be contracted, obliterating the lumen, look as if the gas in the rectum ends high in the pelvis, and with crying or straining, puborectalis muscle in rectum may descend below the ischemium, falsely low estimate of the rectal height. Gas in the bladder means rectourinary fistula. Lower abdominal and perineal ultrasound, CT and MRI define the pelvic anatomy and location in relation to the rectal musculature. Rhombosacral spine MRI identify spinal cord anomalies such as tethered filum terminal. Treatment. The main goals of treatment: closing fistula, relieving obstruction and allowing passage of stool, placement of rectal pouch on the perineum in a good position. Low anomalies: approach, perineal, timing in newborn period, method, using muscle stimulator to determine the site of the sphincter complex, and the anteriorly placed anal opening is completely mobilized and transferred to the normal position. After healing, the anal opening dilated daily for 3 to 4 months to prevent stricture formation and to allow for growth. High anomalies in the past, treated by 3-stage repair consisting of colostomy and mucus fistula formation, posterior sagittal anorectoplasty after 4 to 6 weeks, and closure of colostomy after several months. Recently, a 1-stage repair has been performed by both posterior sagittal and laparoscopic approaches. Continence is most dependent upon a functioning striated muscle complex because anal sphincters are poorly developed, especially internal sphincter. It requires conscious voluntary contraction, preserving the afferent and efferent nerves of the defecation reflex arc as well as the existing sphincter muscles. In all cases, the surgically created anus must be dilated for several months to prevent circumferential cicatrix formation. And this concludes our part for the pediatric surgery for today.